Let's continue looking at opioid analgesics as the main Western pharmaceutical management strategy for moderate to severe pain, but continue to have a look at some of the other important factors that will impact on that management strategy. And once again, using some of the examples of opiates from the list, and some of those that are just classified as opioids, using them as representative examples of some of the pain management strategies that are used. So we said that an opiate strictly just refers to something that's derived from the opium poppy. So something could be an opioid and still work on the same receptor. It mimics the effects of the opiates, therefore, but because it didn't come from the opium poppy, we'll just use the term opioid. With these opioids, the mechanism is still not fully understood. We're going to consider three receptors, delta, mu, and kappa receptors, mostly delta and mu, in this discussion. So at this receptor, morphine and other opioids stimulate the opioid receptor. We do know that what then happens is that there is the release of an inhibitory substance. The substance is called substance P. The site where substance P would normally be released so that pain was perceived and transmitted, it would be released from that dorsal horn neurons in the spinal cord. So if we're inhibiting the release of this substance P, we're going to block the transmission of the pain and the perception then of that pain. Substance P is important in pain fibres that are involved in local inflammatory reactions and perception of pain associated with inflammation. Opioids, as we've said, inhibit pain perception, so this is in the CNS itself. So there is two aspects to the analgesic benefits, and the inhibition in the spinal cord enhances the inhibition further up in the CNS. We do know that opioid receptors are G protein coupled receptors. When you activate this receptor, this actually inhibits production of the enzyme that produces cyclic adenosine monophosphate, cyclic AMP. Recall that cyclic AMP is one of the second mediators often released when G protein coupled receptors are stimulated, but in this case we're reducing levels of cyclic AMP, and the response in the cell to those reduced levels of cyclic AMP is that the membrane becomes hyperpolarized. We're particularly talking about that presynaptic neuron. So therefore, because it is hyperpolarized, it reduces its neuronal excitability. It inhibits the release of pain transmitters that would normally transmit that pain message. This inhibits effects at the cellular level as the CNS feeds back to the tissues. We also know that these opioid receptors experience tolerance effects, where remember there is a gradual loss of the effect. Because this is an inhibitory effect, a gradual loss of that inhibition, and the body overrides the drug, increasing excitatory signaling. So the body aims to increase the levels of cyclic AMP despite the drug. With drugs that produce tolerance, withdrawal is often seen. Here remember that as you stop taking the drug, you then get physiological effects, signs and symptoms of that withdrawal. So it's due to a rebound increase in the cyclic AMP the moment the opioids are stopped. The effect of these suddenly increased levels of cyclic AMP is to affect delta opioid receptors. In the CNS, opioids are indicated for analgesia. Their site of action is in the body. Their site of blocking the pain is pain from the body, but it's working in the CNS. In addition, they might suppress the cough reflex, so they are said to be antitussive. They will also suppress the respiratory centre, and this is one of those major adverse effects that causes death in people who overdose on opioids. Another centrally mediated effect of the opioids is that they cause sedation and sleep. Because of this, they are called narcotics, because they produce narcosis, a sleepy-like state, or they induce sleep. And because they also block pain, they're called narcotic analgesics. So that term narcotic has come to take on other meanings by the police force, in the law, perhaps among the general public, that is slightly different from its pharmaceutical meaning. But if you study the term then analgesic, when a person experiences analgesia, they perceive pain. The CNS and the body working together, but mostly the CNS, to perceive that pain, an analgesic state. So when you have analgesia, the perception of that pain is being blocked. Opioids also produce a euphoria. They do this centrally, that is in the CNS. Euphoria simply means a sense of well-being, an uplifted mood, and this euphoria, this mood, assists with the analgesic effect. But in addition, opioids also produce dysphoric effects, which, as you could imagine, would actually interfere with the analgesic effects. So opioids are known to cause nightmares, hallucinations, and unpleasant feelings. In addition, the pinpoint pupils that is seen with opioids is a central effect, mediated centrally by the drugs working on a CNS opioid receptor. So you often see in addicts, people who are taking opioids and perhaps misusing them, that they have this meiosis, a pinpoint pupil. Opioids can produce nausea and vomiting. Via their effects in the central nervous system, they will produce hypotension and bradycardia. This is often after high doses of opioids. Opioids would not be the analgesic of choice in labour for blocking pain, because these opioids will prolong labour. And in addition, as we have said, they produce tolerance at the level of the receptors. They produce dependence, that is both psychological and physical dependence. Addiction is a property of the person, so they are seen to then lead to addiction in those people who are susceptible. It only takes a few doses of an opioid like morphine to produce that tolerance and those dependencies, so for a person to become addicted. Once again, as we said, when you stop taking drugs like morphine, withdrawal symptoms very pronounced from that sudden rebound increase in the cyclic AMP messenger. So those were the central effects of the opioids. Now let's look at what effects they have peripherally in the body. We said one of the most worrying adverse effects of the opioids is that they lead to constipation, which is quite severe constipation. The reason the person becomes constipated is because the opioid decreases their gastric motility. The drug also greatly increases the muscle tone of the smooth muscle in the gastrointestinal tract. Now, looking at it in a different light, if that is one of the adverse effects of the drug, then that led researchers to think of that as perhaps a wanted effect in a person with diarrhea. So taking an opioid such as loperamide can, by reducing gastric motility and increasing tone, can reduce diarrhea. So that would be an anti-diarrheal drug. Peripherally, opioids also can cause spasm of sphincter muscles. They suppress spinal reflexes. Also, opioids cause the release of histamine, and the effect of that histamine can be to constrict the bronchi, affect the patency of the airways, including the bronchioles. Histamine also leads to an itching reaction, so the opioid has led to a histamine release, which has then caused a pruritus and itching in the skin. People on opioids also describe a sensation as if ants are crawling all over the body. This sensation is called formication. As we heard, they can also produce a dysphoric state, so these opioids, when causing this formication, this sense of ants crawling, if that person was having an hallucination at the same time, they may even see things crawling on their skin. These people may even scratch or pick at these so-called insects that they see crawling over their skin. Opiates, the drugs extracted from the opium poppy, still today have a place in pain therapy. They are effective, strong efficacy in a lot of cases. They're good for places where the pain is caused by a direct mechanical stimulation of those pain fibres. Opiates tend to be best used to relieve intense pain. And if you've already tried the stepwise approach and put the person on a non-opioid analgesic, perhaps a non-steroidal anti-inflammatory or paracetamol, if the pain was not responsive, then you would try opiates, so something that was extracted from the opium poppy, such as morphine. The response to opiates varies dramatically from one person to another, and this is because of the different rates of absorption of this substance. There's also chemical differences. Some substances are more lipophilic than others. If it's lipophilic, it will be better absorbed across the blood-brain barrier. So then, looking at opioids in general, to include the opiates, these drugs might be opioid agonists. They might only be partial agonists at those opioid receptors. And we are going to consider a couple of drugs used in therapy that are antagonists at opioid receptors. So now let's look at a few examples of some opioids. Heroin is a prodrug. Heroin itself is converted to morphine. This is done by enzymes in the liver and is actually the morphine that has the analgesic properties. Heroin has a high lipid solubility, so that lipophilic. It will readily cross the blood-brain barrier, produces a rush of euphoria, analgesia, and other symptoms, but this is of short duration of action, making it not terribly useful actually as an analgesic. Methadone is an analgesic with a longer half-life and a longer duration of action as a consequence, 4 to 6 hours for its half-life. Morphine, on the other hand, to compare methadone with morphine, morphine has a half-life of 2 to 4 hours. So when a person is on detoxification or withdrawal from morphine, that is when methadone is used to reduce the withdrawal symptoms. And we'll also see it's taken by a different route of administration, which can assist with getting that person off the morphine, which they would take intravenously. Pethidine is very effective for analgesia in the short term. We cannot use it for long-term pain relief because it does produce a toxic metabolite. On the other hand, pethidine is less likely to cause that histamine release. So if a person had asthma where they were already at risk of hyperreactive airways, you wouldn't want to give an opioid that led to that bronchoconstriction. So the opioid of choice would be pethidine, one that's less likely to release the histamine and bring on that bronchoconstriction. In biliary colic, there is already a pruritus associated with build-up of breakdown products of heme due to that biliary colic that the person is experiencing in the liver and biliary tree. Because histamine being released will just add to that feeling of pruritus, opioids wouldn't be used in people with biliary colic or perhaps pancreatitis. But pethidine is less likely to cause that histamine release, so is more usable in people with biliary colic or pancreatitis. The use of pethidine then is post-operative for short-term analgesia from pain. One problem with pethidine is that it does interact with one particular type of antidepressant, those that are monoamine oxidase inhibitors. Another opioid is tramadol. In fact, it's chemically unrelated to the opioids, but it still acts at the receptor. In this case, the mu receptor, where tramadol is an agonist. In addition, tramadol inhibits noradrenaline and 5-hydroxytryptamine reuptake, so it's an opioid SSRI analgesic because it has that selective serotonin reuptake inhibition. Tramadol treats moderate to severe pain. It is less effective than morphine, and you'll see that we're going to compare all opioids to morphine, the golden standard. However, it's more expensive than morphine. To weigh that up though, there is another benefit. It is actually less likely to lead to the depression of respiration in the CNS. Because it's also chemically unrelated to the opioids, it has a different effect at that mu receptor. It is less likely to cause a dependence. Codeine produces a lot of dependence, and so in people who are susceptible, they can become addicted to codeine. Codeine is given as an oral formulation for analgesia, but it also stops the cough reflex, so is antitussive. In addition, this is one of those substances that, because of the effects of opioids in the gastrointestinal tract, it's actually used as an antidiarrheal, deliberately to slow down the gastrointestinal motility and to increase the smooth muscle tone in the gastrointestinal tract. The parenteral formulation of codeine might be used for mild to moderate pain. By whatever route it is taken, the codeine is metabolized in the liver to morphine. We'll see not completely that codeine itself has direct actions on the opioid receptor, but yes, some of it is metabolized to morphine, and it is the morphine that then also has another action at that same receptor. So because it is metabolized to morphine, constipation is a very common adverse effect of the use of codeine. Fentanyl is an opioid given orally as a lozenge, but can also be given parenterally, that is by intramuscular routes or intravenous routes. It might also be done as a transdermal patch to treat pain associated with cancer or as a component in anesthesia. It's quite a potent drug, has a very short duration of action, so that's why it's used as a component in anesthesia, and it does have minimal adverse effects. Hydromorphone is a semi-synthetic opioid. So it's something extracted from the opium poppy, but then synthetically altered. Given orally by tablets or as a liquid, and given parenterally for analgesia and as an antitussive to stop the cough reflex. It has a very fast onset, short duration of action, so somewhat like heroin, but we always compare duration of action to morphine in comparison to our golden standard, short duration of action. Oxycodone is another opioid, 10 times more potent than codeine. One formulation available in Australia is a suppository. Fulcodine is an opioid that has no analgesic effects. We still have to study the receptors in some detail, but we do know it's not producing an analgesic effect at that receptor. Via the receptor that it is responding to, the opioid receptor, it is mediating more of those antitussive effects, but in the CNS, Fulcodine also has a sedative effect. The principle with the use of opioids will be to go from the least potent to the most potent in managing a person's pain. So if they are on a Western pharmaceutical, you would see that they had been first put onto a least potent form, perhaps codeine or oxycodone. Methadone we will talk about simply in terms of withdrawal from other opioids, but is counted among the least potent of the opioid analgesics for producing analgesia. Right through to the most potent then at producing that analgesia, heroin, morphine and pethidine in that order. Morphine then, our golden standard, is available as a Schedule 8 drug. Couple of brand names, Ordine and Anamorph. So it is an opiate. It is derived from the poppy seeds, from opium. In the state of Tasmania, there are farmers that are licensed to legally grow the poppy seed for pharmaceutical extraction. Morphine, though it is our golden standard to which we compare all other opioids, may not be as lipophilic as other opioids such as heroin. Morphine is actually quite hydrophilic. It, however, does cross the blood-brain barrier, but at a lower rate than heroin. The other lipophilic opioids, codeine and methadone. Morphine itself is indicated for narcotic analgesia, so blocking pain where inducing sleep would also be warranted. Because of that indication, that's where drugs of abuse and misuse became known as narcotics, other less pharmaceutically accurate uses of the term narcotic. Morphine would be indicated for wherever the pain was chronic, But furthermore, in this stepwise pain management strategy for pain that was unresponsive to non-opioid analgesics. Morphine is also the golden standard by which we compare adverse effects of all the other opioids. So here is the list. This is for morphine, the golden standard to which other opioids either show less or more of that effect. But morphine is associated with that hypotension, respiratory depression, and circulatory depression. It is associated with respiratory arrest. Later, it can be associated then with cardiac arrest, but one of the earlier adverse effects in overdose is that respiratory arrest. With chronic use, though, the constipation related to the decreased gastrointestinal motility. But in addition, other gastrointestinal adverse effects can include anorexia and nausea. In the CNS, morphine will cause confusion and sedation because, as we said, it's a narcotic. We'll have a look at buprenorphine itself as an opioid, but note that when we look at the drugs with which morphine interacts, it interacts with certain opioids such as buprenorphine, producing an additive effect. So shown here is one particular proprietary formulation of buprenorphine, Norspan, where the buprenorphine is being given as a transdermal patch. Morphine will also interact with alcohol or any other CNS drug which produces a depression of normal message transmission. So when used with these other CNS depressants, it will really enhance that CNS depression, so it will really enhance that adverse respiratory depression. The other effect that is enhanced is the hypotension that is caused by the morphine if the person is concurrently taking alcohol or other CNS depressants. Morphine also interacts with monoamine oxidase inhibitors, MAOIs. What is seen here is that the monoamine oxidase inhibitors intensify the effects of the opioids. Furthermore, we consider morphine to interact with opioid antagonists, that is a drug interaction of a pharmacodynamic type. When you use morphine with the antagonists, people who are dependent on the opioid medication might produce some withdrawal symptoms, so that would be a drug interaction. The opioid antagonist is actually being given to minimize withdrawal symptoms, but it may interact and produce some. So then once you have a look at the pharmacodynamics and the pharmacokinetics, you're able to work out where it might be used with a warning or where it might be an actual contraindication. Morphine would be used with caution, so avoid, in people with acute respiratory depression. You'd also avoid it in people who were acute alcoholics, or where there was a head injury that would also perhaps lead to a respiratory depression. Once again, caution in people with acute asthma because of the histamine release, similarly with chronic obstructive pulmonary diseases such as emphysema. If a person had a history of drug abuse, of course you would use morphine with caution as the drug of choice for analgesia. and various other conditions that lead to pruritus. You would use morphine with caution because it also causes pruritus. So pancreatic disorders. If the person is on morphine, which causes lower gut motility and greater tone, you would also tend to avoid in people who had acute abdominal conditions. An example given there, inflammatory bowel disorders. So codeine shown here, one of its proprietary brands, and also showing that often the codeine is given as an adjunct or in a combination with another substance. In this case, ibuprofen, a non-steroidal anti-inflammatory. Also note on the packaging, Schedule 3, at this particular concentration, also given in the packaging, this codeine has to be taken with pharmacist's advice only. Here the codeine might be used to treat pain, so indicated for analgesia, but it might also be used to suppress a cough, so as an antitussive, or in diarrhea, an antidiarrheal agent. Codeine is sometimes Schedule 4 or even Schedule 8, but once again this is the higher doses which tend to be more potent. Once again, often even at this level in combination formulations. So then comparing it with morphine to look at its mechanism of action, it will bind to the opioid receptors in the brain itself. It may also be converted in the liver to morphine. The morphine will then travel in the systemic circulation. Some of it will cross the blood-brain barrier. Though it is quite hydrophilic, it just takes a slower rate for it to cross the blood-brain barrier, and some of the effects might be because of the morphine. But this is only a small fraction of the codeine that is converted to morphine. So codeine in comparison to morphine, our golden standard, about 1/6 the analgesic effects. Codeine is contraindicated in people who have an allergy to morphine. Once again, if the person had a respiratory depression, you would not give a codeine formulation or combination. You would not use codeine in a person who had a history of acute asthma, once again because of that histamine release reaction. So used with caution in people who show dependence, tolerance, or impaired renal or hepatic function, once again because of its pharmacokinetics. Adverse effects of codeine. So once again, compare this with morphine. It does produce gastrointestinal dysfunction and CNS dysfunction, but also some other sites in the body where there are sphincters or smooth muscle. So we have drowsiness, a CNS effect, gastrointestinal upset, but also constipation, that histamine release reaction, effects on the heart, which tend to once again be either central or they might actually be peripheral, but tachycardia or bradycardia, either could be caused. Urinary retention. Codeine can be associated with respiratory depression. Formulations that are Schedule 3 are in such a low dose that the respiratory depression is not likely, but if the person was deliberately overdosing, then this would be a problem. When a person stops taking codeine, they get that rebound increase in cyclic AMP and show classic withdrawal syndromes. Also, the person, when they withdraw from codeine, might get a rebound headache a CNS effect that's caused by that rebound increase in cyclic AMP. There are some opioids that are only partial agonists at their particular opioid receptor. We'll consider the mu receptor, the one that is studied and understood the best. Buprenorphine is actually one of those partial agonists. Remember, it was available as the proprietary brand Norspan. So they produce a less than maximal effect at the mu receptor. This will then make them less effective as analgesics, but buprenorphine able to then be taken transdermally, so one patch, as you can see, lasting 7 days. These that have partial agonistic effects are associated with less analgesia, but they're also then associated with lower dependency potential and less severe withdrawal symptoms. However, warnings and contraindications, compare these with morphine. Their clinical use is not recommended. They may precipitate a pain reaction in a person who's taking other opioids, or they might precipitate a withdrawal reaction to the other opioid while they're on the partial agonist. The other thing too with these partial agonists, if you take an antagonist, the actions of them may not be reversible. Our opioid antagonists are naloxone and naltrexone. They are competitive antagonists because they compete for the drug at the opioid receptor, and they'll displace the drug, our opioid analgesic, from that opioid receptor. And this is how they reverse their effects. Opioid antagonists, therefore, as we said, we'll think of them more as treating the withdrawal or a detoxification from an opiate, usually like morphine. If a person is overdosed on opioids, we might reverse the respiratory depression by use of the antagonist. We might even also reverse some of the sedation. You can see as the antagonist is starting to work that it's opposing that meiosis, the pinpoint pupil, and then the person's mood will come back to a more stable basis. There will be less of those euphoric effects, intense well-being effects. Now, it's important to note, though, that there are other drugs that people can overdose on. They may overdose on barbiturates, a non-opioid drug. And where the barbiturates are causing the respiratory depression, these opioid antagonists cannot substitute to reverse that respiratory depression. Likewise, if it's a CNS depressant working somewhere else in the CNS at another receptor, naloxone and naltrexone won't reverse that CNS depression because it's the wrong pharmacodynamics. It's a different receptor. So we think these opioid antagonists, naloxone and naltrexone, are acting on all the opioid receptors, delta, mu, and kappa. But they're going to have their greatest affinity for the mu receptor. Naloxone is short-acting, naltrexone is a longer-acting opioid antagonist. Adverse effects associated then with the use of these antagonists, once again, gastrointestinal or CNS, nausea, vertigo, headache, fatigue, and nervousness. So we've looked at the opioid analgesics. We do say, though, that you have to correctly characterize that person's individual pain and how they perceive it, and reaction to opioids is variable among people. But one of the important aspects of management was to step up step down as the person reports changes in the way they perceive the pain. So to start off with, you always start off with a non-opioid analgesic, for example paracetamol, or a non-steroidal anti-inflammatory such as ibuprofen. If that doesn't manage the pain, then you try a combination as shown here, ibuprofen with codeine. But there are other non-steroidal anti-inflammatories often used in combination, or first of all before you step up to using them with an opioid analgesic. But review those NSAIDs: aspirin, ibuprofen, indomethacin, diclofenac, and a lot of others. So these non-opioid analgesics are indicated for mild pain. They could also be used alone for moderate pain, or perhaps in a combination with an opioid analgesic, but once again starting with one with low potency and then stepping up as the person reports the reaction of their pain to that medication. Recall also that these non-steroidal anti-inflammatories are indicated for fever, inflammation caused by rheumatoid arthritis, osteoarthritis, and acute and chronic musculoskeletal conditions, or soft tissue inflammations, bone pain, even bone pain associated with metastatic cancer, because it tends to be a mild to moderate pain. Whereas the pain associated with cancer would not be treated with a non-opioid analgesic. Also, we said we'll consider adjuvant analgesics because they can be used to change the way a person tolerates pain. But it does depend upon the type of pain as to which adjuvant or adjunct therapy might be used. So an adjuvant might be used for a neuropathic pain, tricyclic antidepressants. We might use a corticosteroid for the pain associated with inflammation and space-occupying lesions. Though the corticosteroid is not having a direct analgesic effect, simply because it's treating the inflammation, it will have an adjuvant analgesia. And then same thing with the non-steroidal anti-inflammatories. They'll treat the inflammation that will of its own have an analgesic effect because of the reduced inflammation. But these drugs, the non-steroidal anti-inflammatories, in addition will have their own analgesic effect, which will be enhanced by the adjuvant analgesic effect of treating the inflammation. Psychotropic drugs, we saw antipsychotics might also be needed to treat chronic pain or postherpetic neuralgia, that pain that's caused after a herpes infection. Use of bisphosphonates to increase bone density might be used as an adjuvant to analgesia, perhaps in people receiving cancer therapies. Clonidine is another drug that we'll continue to look at as we look at drugs acting in the central nervous system. It's commonly an adjunct to local anesthetics or to opioids to manage pain. Capsaicin was one of those neuromodulatory substances that is being investigated as a drug. There are certain sensory fibres that are known to be capsaicin sensitive. You get a better management of that person's pain if you use the capsaicin as an adjuvant. Similarly, ketamine, which is currently indicated perhaps as a general anaesthetic, but we're saying it could also be used as an adjuvant because it's neuromodulatory. Gabapentin, we're going to look at once again in further detail when we go on and look at other drugs that work in the central nervous system. It's an anticonvulsant. These anticonvulsants, though, also tend to be good for that neuropathic pain, the one that does not respond terribly well to opioid analgesics. So gabapentin is another neuromodulatory substance. We do stress that with Western pharmacological management of pain, it has to be stepwise. The aim is to manage the pain so the patient will recover better, recover function, activities of daily living, better control over their lifestyle, but often that might need to be in conjunction with a complementary therapy. Certainly if you're going to get the person off, step down completely their Western pharmaceutical pain management strategies, then you want to have another plan in place to then help that person manage the pain so they don't need to then come back onto the Western pharmaceutical treatments that tend to have a higher level of adverse effects. So it's all about assessing the pain, evaluating the pain, looking at the individual, all of those factors we talked about that impact age, what other conditions that they have concurrently, what drugs they may be taking, their history, whether they might have morphine abuse or they may have shown an allergic reaction to histamine, to morphine, that histamine release reaction. So you want to assess the pain quite thoroughly. In step 1, if it's a mild pain that a person might rate at 1 to 3, we'll use non-opioid means, non-steroidal anti-inflammatories, but also preferably non-pharmacological means. It might be these non-pharmacological means, your complementary therapies with an adjuvant, something to treat, say, their depression. That might even also be a complementary medication, a herb that you're using. At that level, if the pain is not controlled or the person is rating it higher, increasing pain will step up the management plan. When they start rating it at about 4 to 6, we'll now say this is a moderate pain. We'll still keep using non-opioids, but perhaps the weak opioids, those that had a low potency, such as codeine, where we can use it in combination with non-steroidal anti-inflammatories, but definitely still in combination with non-pharmacological means of management of that pain, so complementary therapies, lifestyle management factors and so on, but also with adjuvants. If the pain then still increases, then we'll step up. If it improves, we will step down eventually to taking the person off the Western pharmaceutical management, getting them back on a non-pharmacological management of that pain. So, complementary therapies. But if it increases, the person starts rating the pain at 7 to 10. We now have a severe pain where opioids are definitely the drug that is indicated. That might be with or without adjuvants, and that might also still need those non-pharmacological strategies to work on the person's psychosocial factors. Opioids do have major adverse effects, so that's why it is important to step down when that severe pain has been managed, to manage the adverse effects of constipation, nausea, vomiting, sedation, but mostly the respiratory depression that is such a danger in overdose, where the person at the uses of the opioid for strong pain might be developing tolerance effects and might then be taking more of the medication than they were supposed to, getting into overdose levels, the risk of that respiratory depression then being such a strong risk factor for stepping that person down from the opioids when you can. So always monitor, prevent any adverse effects, intervene when appropriate. So if you're the natural therapy practitioner working with the general practitioner to manage this person's pain, that's also you that has to step in and intervene wherever necessary to make sure that the step down is happening when pain is starting to be managed.